Matters. Thank you so much for joining us today. My name is Sahru Keiser, and I'm the Education and Mobilization Coordinator at Breast Cancer Action. Joining me on the webinar today, we have two presenters. The first is Galen Joseph, Assistant Professor in the Department of Anthropology, History, and Social Medicine at the University of California, San Francisco. We also have Maria Caprio, who's the Director of Shanti's Breast Cancer Program. So a few quick announcements before we get started. Stay tuned for our next webinar, which will focus on our Think Before You Pink campaign. You can look for details on our website at www.bcaction.org. Breast Cancer Action doesn't take any money from corporations that profit from or contribute to the breast cancer epidemic. Our work is largely supported by individual donors. $1 donation today to support work like these educational webinars. Before we get started, I just want to go over a few rules of webinar etiquette. The presentation of Reducing Inequities in Breast Cancer, Why Experience Matters will last about 45 minutes. We'll leave time at the end for all of your questions. Everyone except the speakers will be muted during the webinar to cut down on background noise and to ensure that we can all hear well. And last, we really would like you to get involved with Breast Cancer Action. This webinar is a great way to do that. Please stay tuned for other ways we'll mention later on. So I'm going to start with our agenda. We're going to start by talking women continue to face after access to health care is obtained. Galen will talk about a study she conducted looking at the effects of low health literacy, language barriers, and culture in genetic counseling sessions. And Maria will talk about the experiences of breast cancer patients at a nonprofit serving the needs of a diverse urban population. We'll end with a short conversation about next steps. So Breast Cancer Action was founded in 1990 by a group of women who were frustrated with the lack of information about breast cancer. Our founders, only one of whom is still alive today, knew that their private medical crises were part of a larger public health emergency, and that the experiences of those dealing with breast cancer needed to be heard to address the crisis. Breast Cancer Action's mission is to carry the voices of people affected by breast cancer to inspire and compel the changes necessary to end the epidemic. Our advocacy is conducted through a social justice lens because the politics and policies of breast cancer disproportionately affect poor women and women of color. Breast Cancer Action's independence from pharmaceutical company funding puts us in a unique position to address issues of health equity and exposures to toxins in our environment, and to put the needs of patients before pharmaceutical company profits. We have three main program priorities. The first is putting patients first, where we advocate at the Food and Drug Administration in favor of treatments that are less toxic, more effective, and less expensive than those already available. We also provide information about breast cancer to anyone who needs it. Our second priority is creating healthy environments, where we work to reduce the involuntary exposures people encounter that put them at risk for breast cancer by holding corporations accountable for unhealthy products and practices. We also support legislation that would better protect us from chemicals in our environment and that would make personal care products safer. The last priority is eliminating social inequities related to breast cancer, where we work to create awareness that it is not just genes, but social injustices, political, economic, and racial inequalities that lead to disparities in breast cancer incidence and outcomes. Again, my name is Sahru Keiser, and I'm the Education and Mobilization Coordinator here at Breast Cancer Action. I work on educating the public on issues of health inequities related to breast cancer and mobilizing Breast Cancer Action's national partners on inequities issues. Galen Joseph, our other presenter, is an assistant professor in the Department of Anthropology, History, and Social Medicine at the University of California, San Francisco. Her research covers the socio-cultural and institutional dimensions of inequities in cancer care. She's focused specifically on clinical practices and social implications of breast cancer genetics among economically and ethnically diverse women, and recruitment to cancer clinical trials among medically underserved and/or vulnerable populations. Galen is a founding member of the International Network for the Comparative Understanding of BRCA breast cancer gene research and medical practices, an interdisciplinary working group which aims to understand the development of research and medical practices related to the BRCA genes in national multiple contexts. Also joining us, Maria Caprio. Maria joined Shanti in 2008 as the director of Shanti's breast cancer program. Prior to joining staff, Maria was a Shanti peer support volunteer since 2007. She's a longtime volunteer with the Human Rights Watch in Northern California, has volunteered for several months at Mother Teresa's Palagat Home for the Dying in Calcutta, India, and organized the first annual Land and Sea Environmental Cleanup Campaign in Taganga, Colombia. Maria has a BA from Scripps College in International Relations and was a Margaret Hart Scholarship recipient. Shanti's breast cancer program provides practical assistance and emotional support to underserved San Franciscans with breast cancer. As a community-driven collaboration, they collaborate and build upon a continuum of health, social, and complementary care, and draw upon the support and assistance of our consortium members to conduct outreach and ensure that clients are receiving the entire spectrum of assistance and support available. So I wanted to start by reviewing what we talked about in part 1 of our Inequities series webinars. And for some of you who weren't there, the webinar is available on our website, archived, and you can watch it anytime you want. So in the first webinar in Inequities in breast cancer, we talked about what breast cancer inequities in incidence, mortality, and survival among different racial and ethnic communities looks like. We also talked about the social determinants of health, which is where you live, work, and play, and really the importance of race and place to those factors. What we saw in that webinar was that although there have been small, and I want to put an emphasis on small, decline or death rates, the decline has not been equal in all communities, and even some is still on the rise, and slower compared to white communities. There are also still large differences in survival rates between communities, with American Indian, Alaska Native women, and Samoans still showing very, very low survival rates. Over and over, what the numbers showed us in that webinar and also just in research is that women of color have lower incidence of breast cancer. They continue to present with more advanced and aggressive breast cancer at younger ages, and their rates of survival are significantly lower than white women. There's also growing data that suggests that access to early, regular, and appropriate breast cancer screening, detection, and treatment really only explain part of this burden of excess mortality. And there are really some other factors that come into play when we look at after a woman has access to care. And these factors are still continuing to fuel the inequities that we see. So I'm going to talk a little bit about what those barriers are, but I want to first start just by talking about how important gaining access to health care is. And I really want to make the point that this webinar is not to say that health care is not important. It is a crucial, crucial part of ending the inequities that we see. And what we know is that 49 million non-elderly people in the United States have no health insurance in 2010. And we also know that the Affordable Care Act, which the Supreme Court upheld last month, or a few months ago now, is really a big step in delivering care to over 30 million of those uninsured Americans, and also making preventable services more accessible. We know that communities of color have substantially higher numbers of uninsured, and sort of the typical uninsured person is a young adult who is from a community of color in a low-income family where there's at least one working adult. Over half of the uninsured have a chronic disease like cancer, and the lack of adequate health insurance means that women are less likely to receive adequate, timely care. So we can see that health insurance is just critical, but we also know that it's not the full picture. It doesn't solve the problem. So when universal access to medical care is ensured, we still continue to see racial disparities in breast cancer diagnosis and outcome. So while we need to continue to push for access to health care, we also need to understand and overcome the barriers that women continue to face. So in 2003, the Institute of Medicine released a report titled Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. And it really shocked some people, was that race and ethnic and health disparity, and that people of color tend to receive health care. About what some of those barriers are in the next couple of slides. So by 2050, it's estimated that almost half of the U.S. population will be non-white. Nearly 14 million Americans are not proficient in English, are women with language barriers. And through lots of research and studies that language barriers exchange of information. There's a loss of information, there's miscommunication issues, and it also leads to poor shared decision-making with a provider and a patient. All of these things can affect how patients adhere to treatment, having poor follow-up, and also just a decreased satisfaction with the patient-provider relationship. And I'll talk a little bit more about that a little bit later. Language barriers likely affect a woman's ability to obtain a breast cancer diagnosis. It can inhibit initiation of treatment in a timely manner, and it can really have a negative impact on the stage of diagnosis and possible survival and survivalship. Galen is going to talk a little bit more about her study and how these barriers are specific, how these barriers specifically affect communicating breast. So the Commonwealth Fund did a study looking at communication between patients and providers. And this was not specific to breast cancer, but I think it can help show some of the issues that I was talking about. And it really found that an overwhelming majority of people from communities of color experience communication problems. And it's not just a matter of a language issue, but sometimes there's cultural miscommunications and barriers, and these can be related to racism and discrimination. And I'm going to talk a little bit more about that as well. So Healthy People 2010 defines health literacy as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. Now, individuals with limited health literacy have been shown to have greater difficulty in communicating with their providers. They're less likely to participate in shared decision-making, and they really face greater barriers in managing chronic illness. Furthermore, the limited health literacy appears to be a barrier in accessing care, receipt of preventative and self-management support services, and also safe medication management. And now, you know, health literacy is not just about patient capacity, but it's also really about health literacy demands of a healthcare system or a facility. And there's really a strong need to not only address helping patients deal with health literacy issues, but it's also creating better health literate systems and medical facilities so that we're really increasing the health literacy skills of patients and promoting health literate healthcare organizations. So the first piece of racism and discrimination that really is and can be a barrier that affects the health care that women get after they have access to health care services is racial residential segregation. And I actually talked a little bit about this in the first webinar. And what is racial residential segregation? There were policies all the way up until the 50s in the U.S. that policies in housing that led to people of color systematically being denied opportunities to live in certain areas. And so what this has done is we can see the effects today of neighborhoods that still are high and one of the access to health services, health insurance or not. So regardless of income level, some studies have shown that living in a majority African American community means a higher concentration of poverty, fewer jobs, under-resourced schools, fewer grocery stores, fewer basic services, real need to address housing policy as a way to address health and health disparities. Another factor is really the patient-provider relationship. And some literature, the IOM report being one of them, showed that patient may be affected by race. So this is subtle and can result in different clinical recommendations being given for patients of different race or ethnicity or even socioeconomic status. It can also influence factors such as, going to comply with their treatment recommendations. Their decisions, it's also affected by their ability or inability to navigate the medical system. Really prohibits a good communication with a patient and a doctor to less information. Suggests that the gap in the delivery of doctors to patients, providers communicated differently about breast cancer treatments with patients of different African American patients, received less information about different medical treatments. So this also plays into institutionalized racism. So it's not just about patients, but it's to provide appropriate and professional services to people because of their color, culture, or their ethnic origin. And we see this through the breast cancer care continuum from prevention to diagnosis, treatment, and through support options. Again, as I said, the IOM report really looked at a large body of published research and saw that racial and ethnic minorities experience a lower quality of health services and are even less likely to receive even routine medical procedures. So a study in 2006 found stage breast cancer and found that they had double the risk of white women to receive necessary adjunct treatment despite rates of oncological consultation similar to white women. Also, a 2007 study found that black women were 3 times less likely to receive chemotherapy and 5 times less likely to receive tamoxifen. So we see that racism and discrimination run deep, and there are both patient and provider issues as well as larger health system issues. So one of the things that I sort of alluded to in talking about patient issues around racism and discrimination was a mistrust of the medical system. And there's really a long history of the medical system taking advantage of vulnerable populations. In all communities of color, there are sort of historical forces that have left a real legacy and continue to result in discrimination and also result in, for each sort of racial or ethnic community, there is some example or many examples of the medical system taking advantage of these populations, vulnerable populations. 7 of color in a way that can really fully serve your needs, and also even going to the doctor. It really affects seeking preventative care services. So there are a couple other barriers. Currently, there are only 3 oncologists in the U.S. who are of Native American descent and 184 from descent. To an oncologist, and you're looking for a proportion of underrepresented nationals. And I talked a little bit about how communities of color and white communities are sometimes offered different treatments or given different services. But there's also the idea or the fact, really, that physicians who serve primarily low-income communities of color report that they're less able to access resources for their patients, which includes specialty consultations like oncologists and also diagnostic tests. So really, where you live can play a role in what resources you have access to, and sometimes that even becomes normalized, this substandard of care. There's also the physical accessibility. So if the services are not available in your neighborhood and you need to get to a facility that's far away, if you don't have or you don't have access to a car and public transportation is the only way that you can get places, then getting places, taking numerous buses and public transportation, barriers that are sort of related is having to get preventative care, to do follow-up appointments and receive treatment. And also, if you are the sole provider of child care or caring for another family member, being able to find someone to relieve you of those duties so that you can. So there's really a number of barriers And I'm going to turn it over to Galen now, who's going to talk a little bit about a conducted looking for and communicating breast cancer genetic information.
Thank you, Sahru. I'm delighted to be here and to be a part of this webinar. As Sahru said, I'm going to talk a little bit about some research that I've been doing for the past few years. Specifically, I'm going to talk about a pilot study with Latina women, but I have been conducting research in a public hospital where low-income women have been able to access genetic counseling and testing for breast cancer for free since 2002, in part through grants from the Avon Foundation and more recently through Medicaid funding and through a research study. Next slide, please. Before I get to the specifics of that study, I'm going to talk a little bit or provide a little bit of background on hereditary breast cancer and disparities or inequities in care. And I'll briefly touch on the purpose and methods of the study, some preliminary results, and some conclusions and next steps. Next slide, please. So some background on hereditary breast and ovarian cancer syndrome. So many of you may be familiar with the BRCA or BRCA genes. These were discovered in the mid-1990s, and they've received a lot of attention. But it's important to note that only 5 to 10% of all breast cancer is actually due to mutations in these breast cancer genes. However, they do confer a very high risk. So a mutation in a breast cancer gene, BRCA1 or BRCA2, can confer up to an 80% lifetime risk for breast cancer and up to 40% lifetime risk for ovarian cancer. And studies have shown over the past 15 to 20 years that genetic counseling can improve quality of life, and genetic testing and preventive measures such as prophylactic surgery can reduce morbidity and mortality. And so genetic counseling and genetic testing have become the standard of care. Next slide, please. The prevalence of BRCA mutations is still under study, but what we know so far is that the prevalence of these mutations is really similar across all the U.S. ethnic groups, except Ashkenazi Jews, where it's significantly higher. However, we've also found that while people of color make up 35% of the U.S. population, less than 13% of those who receive BRCA testing in the U.S. are people of color. So there's a clear difference in who has access to this testing service. Studies have also shown that medically underserved patients, so people of color, low-income people, people of lower literacy, have less knowledge of genetic counseling and testing and less access to these services. And specifically, research on Latinos has shown a lower awareness of breast cancer genetic testing and low knowledge of hereditary breast cancer. However, despite this low awareness and knowledge, Latinos of different sub-ethnicities have expressed interest in the services and also seem to accept the services at high rates when they are offered. Next slide, please. So the barriers that we see in genetic counseling and testing are similar to the healthcare barriers that we see in other areas of medicine and the barriers that Sahru has discussed. So we see socioeconomic barriers or barriers related to socioeconomic issues, language, insurance, poverty, access to knowledgeable providers who can make the appropriate referrals where low-income women obtain care, issues of literacy and specifically health literacy, medical mistrust, and perceived disadvantages, psychosocial barriers. And then the one additional barrier is a technological barrier. So there's a program called BRCA Pro, which calculates the risk or the likelihood that a woman will have a BRCA mutation. And the applicability of this program, which in many cases is used to determine whether someone is offered the genetic test, the applicability of it to minority populations has really been called into question because it was developed with white families. And so the relevance to families of color has not been proven, and there's some indication that it definitely does not apply equally. Next slide, please. So what we're seeing is that advances in genetic medicine can exacerbate breast cancer disparities if low-income women are unable to access and benefit from genetic risk services. So Medicaid has begun to reimburse for cancer genetic services in many states, about 26 so far. So there's increasing access to genetic counseling and testing. However, financial access alone does not ensure effective communication. And what I mean by effective communication is when a message reaches the intended audience and where the meaning is mutually understood. So the Institute of Medicine report that Sahru referred to earlier showed that gaps in effective communication contribute to health disparities. So even though more women are accessing genetic counseling and testing, we want to make sure that there's actually effective communication in those counseling sessions and about genetic testing to ensure that disparities are not perpetuated. Next slide, please. So in the genetic counseling process, there are many opportunities for miscommunication to occur. And I'm just going to touch briefly on some of these today. I won't have time to discuss them all, but just so that you have an understanding of what that process is and how much communication goes on, there's really 4 steps. So there's the referral process, and many people show up at genetic counseling not really understanding why they've been referred and what to expect or what they think is going to happen in that appointment. The first appointment is typically an information and education appointment where the counselor collects the family history from the patient, explains the BRCA genes and genetic testing, and assesses the appropriateness of testing based on the individual and family history of cancer. Frequently there'll be a second appointment where the patient will provide a DIT in the interim, and the counselor will re-explain the BRCA genes and testing, and together the counselor and patient will make a decision about whether to test. And if a research study is involved at all in the testing, there'll be consent for the research process. And in addition, the patient will typically have to sign a consent just for the test because it's a genetic test. And then there'll be a third appointment where the counselor explains the test results and the implications for the patient and her family and provides recommendations for follow-up care. So again, the main point here is that there are many opportunities in the genetic counseling process for miscommunication to occur. Next slide, please. So the purpose of my study was to identify communication gaps in breast cancer genetic counseling with low-income Latino women. And I used qualitative methods, clinical observations of the genetic counseling appointments, and interviews with patients after they receive their test results. And I've just listed some of the characteristics of the participants in the study, and as you can see, they're very diverse in terms of education, immigration status, countries of origin, and about half had breast cancer and half had no breast cancer diagnosis. Next slide, please. So some of my preliminary results show that there were gaps in communication in these 4 areas of interpretation, so translation. Most of the participants were Spanish speaking, and some form of interpreter was used in the genetic counseling appointments. Communicating about family health history, literacy and understanding of genetics, and understanding genetic test results. And I'm only going to have time today to talk about the second and third. Next slide, please. So a key component of genetic counseling communication is the elicitation of a patient's family history. And this can be a challenge, immigrants. The difficulty of obtaining the information from other family members who are in the home country increased the difficulty or the challenge of communicating that family health history. So for example, this 38-year-old woman was her family was residing in Mexico, and her skin cancer, and the counselor ovarian cancer she had, because some than others. So it would help her in assessing whether it was appropriate to test the patient before her, and whether it was likely that she would have a genetic mutation. So in interviewing this patient, she said, "We talked about family, about my whole family, about my parents, everyone, about the generations. The counselor asked me if I could give them all to her. I was so embarrassed that I couldn't say. How could that be?" So she really, she felt as unable to communicate or to provide all of the information that the counselor was seeking. And then another aspect, this same patient talked later in the interview about some of the challenges of finding a family's health history due to some of the and cultural beliefs about cancer in her family. She had explained to, so the genetic counselor asked if there was any chance that for the aunt who had died of stomach cancer, if the cancer had started in some other place, such as the ovaries. And the patient said that she didn't know, and they were pretty advanced and they were dying. So as you can see, the ability of the patient to gather information from her family was affected partly by the cultural beliefs in the family, partly by the access to information, to medical records at such a great distance and across national boundaries. Next slide, please. So health literacy and the ability to understand what the genetic counselor is explaining about genetics was also a challenge for many of the patients that we observed. This patient was from Mexico and had less than an elementary school education. And she told us in her interview, "I only knew that they were going to take blood and they were going to do so for a genetic test." But she already started to explain to us, "I don't know how to say it to you, because it was already, it has, one does not understand." So what she's saying here is really that she didn't understand literally some of the words that the counselor and the interpreter were using in her genetic counseling session. And so her ability to fully understand what it meant to have a genetic test and what the implications of that test were really limited. And then another woman that we interviewed did have a better understanding. So I want to show you this to give you a sense of the range. Own family, it gets passed on like that. That's what I think. So here she general idea, something is transmitted and passed through the family in the blood. But the specifics of genetics and genes is a bit lost. Next slide, please. So what we want to do in the future, based on the results of this study and our other work, is to build on the communication strengths that we saw with the counselors. And we did see that the counselors are effectively able to provide reassurance to patients who fear a positive test result. They're able to communicate basics of hereditary breast cancer. So the idea of passing something on in the family generally gets across. And then we did observe a couple of English-speaking Latina patients, and they really did seem to have a much better rapport. The counselors had a much better rapport with the English-speaking patients. And so something is definitely being lost in the translation with the interpreters. So we want to build on their skills at building rapport and ensure that there's adequate interpretation that is able to communicate that rapport. We want to make sure that the explanations of BRCA genes are more accessible to persons of lower literacy. We want to facilitate question asking on the part of the patients so that they're more comfortable asking questions when they don't understand a word or a concept. And then we also want to ensure that there are clear take-home messages to communicate risk status and screening recommendations for patients and their family members, both for women who receive negative and positive test results. Next slide. So thank you very much. I want to thank also the genetic counselors and the patients who participated in the observations and interviews, my research associate, Claudia Guerra, and our funders, the UCSF Hampton Medical Research Fund. Thank you. And Caprio from Shanti.
Thank you for that great presentation, Galen. And hello, everyone. My name is Maria Caprio, and I have the honor of being the program director of the Shanti Project's breast cancer program located in San Francisco. We're so grateful that Breast Cancer Action asked us to be a part of this discussion today, speaking to the health inequities that we at Shanti, a community-based organization, see our clients face on a daily basis. So without further ado, let's get started. Next slide, please. For the next several minutes, I'm going to talk about how our program came to be, the needs of our community, and how Shanti addresses those needs. And finally, I'll touch on the importance of collaboration across systems, medical, community, and research efforts working together to bridge the gaps in health disparities. Next. Our agency, the Shanti Project, was founded 38 years ago in San Francisco and became one of the first community-based organizations to respond to the AIDS epidemic, providing free case management, advocacy, education, and emotional support services. And because of Shanti's legacy in the AIDS community, the Department of Public Health approached the agency in 2001 to pilot a program in collaboration with the local safety net hospital. Because they found something that that might surprise you, which was that while access to screening was on the rise and more low-income and minority women were being diagnosed with breast cancer, many of these women were not making it through their treatment and were disappearing in the system. A system that technically had removed the barrier to access to care with the provisions of Medi-Cal and the legal sanctuary status of the city. So why still were treatment adherence rates remaining lower than expected and mortality rates still high? Well, the findings of the assessment recognized that San Francisco's public health safety net system serves a very diverse population, spanning the socioeconomic spectrum and includes large immigrant communities. The findings echoed much of what we've already heard today, that low-income and underserved women and men often face multiple practical, psychosocial, and systemic barriers that negatively impact their ability to adhere to treatment. And many of these barriers exist outside of the medical model. In the next few slides, I'll describe who our clients are and some of the they face, treatment aside. Next slide, please. So I'm going to assume that for many of us participating in this webinar today, we have or had a breast cancer diagnosis, or at least know someone who has. So we're intimate with the challenges that one faces when going through the experience of being treated. With that in mind, I'd like you to imagine what it's like for a typical Shanti client facing these challenges. We use the words underserved and vulnerable often to describe our clients. But what does that really mean? Well, for starters, the average Shanti client is low income, living on an average of $200 after rent each month. The anxiety around personal finances is often paralyzing, especially for 70% of our clients who are unable to work during or immediately after treatment. And for many of us who have children of our own, we can only imagine that for the 1 in 5 of our clients that have dependents, the immense stress of finding affordable child care is incredible, and that when these women are forced to choose between their children or their own care, their children are often their priority. Next slide. For those of us who live in a large city, we know that depending on the bus schedules to make critical appointments can be a challenge in its own. Now imagine what it must be like for 76% of our clients that rely on the bus, or maybe 2 buses, to get to medical appointments. For many, it takes no less than half a day to get to and from one appointment. And for those suffering from nausea due to chemotherapy, it's not hard to understand that the stress of public transportation can be enough to forego the appointment altogether. So to reduce this stress, our navigators help our clients access additional transportation resources, including our own taxi vouchers, and offer to accompany clients to their appointments. 64% of our clients live alone or have limited family or friend networks to help them with care management and basic daily errands. Tasks that prior to treatment were easy, like walking to the laundromat or grocery shopping, often become impossible. For these clients, in addition to our staff calling and visiting them regularly, we also offer to match each client with a trained Shanti volunteer who visits the client once a week to help with basic tasks and provide companionship, and essentially becomes another pair of eyes and ears for the care team. And in addition to a breast cancer diagnosis, at least 45% of our clients already live with a long-term disability or life-threatening illness like diabetes or heart disease, which further complicates their medication management and appointment schedules. Next slide, please. As the pie chart on the right illustrates, our program's ethnic diversity reflects the ethnic breakdown of low-income and underserved communities in San Francisco. And layered underneath these ethnic categories and within our immigrant populations, approximately 56% do not speak English as a first language, and of that, 32% speak only no English at all. So for these women, going to the hospital is literally a foreign experience. Next slide, please. Another way to look at the many facets of an individual's life that play a role in how and to what degree they're able to manage their care is this patient-centered echo map. Our navigators use this with our clients to assess where it is that they may need help. The concentric circles depict the various stages of breast cancer care, and the individual elements denoted in the boxes can represent either a barrier or a strength while someone is undergoing treatment. These elements often shift. For instance, prior to treatment, a client of ours was able to still afford to go grocery shopping and make her own food. She'd explained to us that this activity was really important to her because it made her feel independent and empowered her and allowed her to get out of the house to socialize. And so initially, she had declined when her Shanti navigator had suggested that she apply for a local food delivery service. Well, unfortunately, a few weeks into treatment, she became so fatigued and ultimately homebound that not only could she not physically get to the food and prepare it, but she could no longer afford the grocery bills, and so was grateful to have access to this delivery service. Next slide, please. But as both Sahru and Galen have expressed, one of the most reoccurring systemic barriers that we see our clients and their care teams challenged with is communication. Many of us are fortunate enough to have an established relationship with at least our primary care provider, but these women don't. And with many of our clients uninsured prior to diagnosis, this is the very first time that they're meeting their doctor. So there's no previous rapport or trusting relationship to build off of. And in a time of crisis, this can hinder timely and crucial information sharing. Another is lack of self-advocacy skills. For many of our clients who come from different cultural backgrounds, they may have been taught to defer to what the doctor is saying and aren't used to asking questions or exploring options. Or their English might be limited and they're not comfortable with admitting that they don't understand what's being said. And especially if they're undocumented, they might be afraid to upset the doctor and be found out. And in addition to these communication challenges, we also see the issue of inconsistent symptom reporting. A client might report to the doctor that they have a pain, but not explain in depth, or if it persists, forget to mention it, and in subsequent appointments and forget to remind their doctor to note it in their files. So worst case scenario is it goes untreated, or because it isn't being documented, they might lose eligibility for crucial social services like in-home support. Next slide, please. Okay, so allow me this brief moment to brag a little bit about my city. San Francisco has a great public health safety net system, no doubt. But even as such, the need is often greater than resources can afford, and the system's limitations can challenge even the most cooperative patient. For example, oftentimes our clients have appointments scheduled for, let's say, 1 o'clock in the afternoon, but don't actually get seen for a couple of hours later. In-person medical interpreters are also really limited, and when a patient's appointment is delayed, that scheduled window with the medical interpreter is forfeited. So then the question becomes, should the appointment be rescheduled, or do the patient and the doctor try their best to muddle through? Our general hospital is a great teaching hospital, and so it's also not uncommon that a patient will come to an appointment, and instead of seeing their doctor, they're seen by a student doctor or spend the majority of the appointment with an attending nurse. Unfortunately, a sense of mistrust or from unfamiliarity or feeling of being diminished can add to a client's anxiety. Finally, we also see a lack of coordination between the patient's various providers, especially for hospitals that don't have shared electronic systems. This can lead to overlapping appointments, prescriptions that counteract each other, and an incredible amount of responsibility put on the patient to make sure each provider is kept up to date. Oftentimes, even if a patient shows up regularly, they can still get lost in the system. Next slide, please. So to bridge these gaps that can undermine care, we offer our clients high-intensity case management with emotional support, or what we call at Shanti, care navigation. As an example, I'll take you through a brief case study of Joan and her Shanti navigator, Mabel. For Joan, in addition to breast cancer, she was also being treated for a recent brain aneurysm and recovering from a subsequent surgery. Joan lived in a 2-story walk-up with her 83-year-old sister, who was her primary caregiver. The rest of her family lived in the East Coast. So whenever her sister couldn't take her to an appointment, which was about 50% of the time, Mabel, her Shanti care navigator, would coordinate to pick her up from her home and accompany her. Mabel also connected Joan to several community resources, including food, financial assistance, and in-home support services. As a side effect of chemotherapy and brain surgery, Joan also suffered from memory loss, making it difficult for her to remember the questions she had planned to ask her doctor or the responses she was given when she did ask. So Mabel would often help her to list questions prior to appointments, remind her of her symptoms that she wanted to discuss, and take notes during an appointment for Joan. Joan also had a hard time remembering all of her prescribed medications, and so Mabel made her a list for her to carry with her at all times and made sure to present it at each medical appointment. Next slide, please. So because Shanti has the flexibility to meet with our clients both inside and outside of the clinical setting, and we're checking in with our clients at least once every 2 weeks, if not more, our navigators get a really deep sense of who the client is and what their needs are related to their life outside of the doctor's office, and can often troubleshoot issues before they reach crisis. Gaining an intimacy with a client's baseline around activities of daily living, such as getting out of bed or transitioning from sitting to standing or eating, and then also what we call more complex instrumental daily activities, such as food preparation, laundry, financial management, and housekeeping, can be incredibly powerful in supporting their care. Next slide, please. This slide is just a quick summary of our collaborative model with our local hospital system. As soon as someone is diagnosed, they are referred to our program, and then we become part of the care team, making sure that the client is accessing all of the resources available to them. And we've been incredibly successful for the past 11 years. Next slide, please. As shown in our 2011 annual client survey, 100% of our clients were able to access medical treatment. 85 completed their prescribed treatment regimen, and 98% of our clients agreed that their quality of life had improved due to our services. The doctors, nurses, and social workers that we work with know that Shanti can mean the difference between a client completing the chosen treatment or falling through the cracks. Next slide, please. So if there's one takeaway from today that I'd like to share with everyone, it's that there really is no one system, entity, or person that can eliminate all of the disparities we see affecting our clients. But collaborative models linking hospitals and trusted community organizations, as well as the research community, can cover so much more ground in bridging gaps and empowering the individual. Community-based organizations like Shanti can be an integral member of an individual's care team. And communication and education are also important areas for furthering collaboration. In fact, our program is currently working on a research project with UCSF research team led by Galen to investigate if Shanti can be an effective resource for clinical trials education for our clients who typically do not have access to culturally and linguistically appropriate information on the topic. So we are really lucky in San Francisco, again, to have such a close relationship with the Department of Public Health and our local hospital for so many years. But we're still limited in being able to prove our efficacy in terms of measurements that are recognized by the medical and research communities. Measuring a person's sense of well-being is what we deem to be most important. Certain terms have yet to gain the same value in the medical system. And when funding is being cut, often the non-medical services are the first to be affected. So the big question is, how do we make effective community-based interventions financially sustainable and scalable? If we can figure this out, if we can achieve these things, ultimately the chances of healthier outcomes for women dealing with breast cancer can be exponentially increased. Next slide, please. So thank you for listening, and thank you to Breast Cancer Action for inviting us today, and of course thank you to our funders. We really enjoyed being a part of this. Thank you.
Thank you. Thank you both to Galen and Maria for really giving us a sense of people's lived experiences through the breast cancer care continuum. I want to just appreciate everyone's attendance, and I know that we are running a little late. We have a few more slides to go, and then we're going to try to have time for questions. So I understand if people need to leave, but if you can stay on and write your questions as we continue the presentation, I really appreciate it. So I wanted to a little bit about, I think I said in the big action is real advocacy organization, but we also provide some direct services through offering information and referrals to anyone who needs it. We also work collaboratively with direct service organizations like Shanti to really bring these lived experiences into the policy and advocacy agenda. We're actually in the process of developing a new pilot program, a Speakers Bureau program, which is modeled on the community health worker and promotora programs, which reaches out into communities to train community members not only to bring breast cancer advocacy issues into their communities in a culturally relevant and respectful way, but to also serve as a bridge and to hear from those communities about what advocacy issues are most pressing and relevant to them. And as we continue to move and hopefully push to move beyond individual behavior change to systemic change, do that through our priorities, through putting patients before profits, through creating healthy environments and addressing the root causes of inequities. Because although medically competent interpreters is very important, that's not the only issue. We need to understand why we need them and why they're important. We need to talk about what are the changes at the systemic level that maybe would result in reimbursement for medical interpreters, for professional development, for really understanding how they can be tied into a larger model where they're considered integral And the other are really a diverse group, and depending on who you are, and really can depend on what you can do and what you want to do to address ending inequities in breast cancer. We know in our audience there are women living with breast cancer. There are women from underserved communities, health professionals, students, community activists, and more. Some listeners may fall into a number of these categories. And again, we really would like to invite anyone who's interested to join our Speakers Bureau and really help with the answers to solve the problem. This is really an open conversation where we can all work together towards change, and to know that there aren't any easy answers, but we will never let the issues go away just because it's not easy to do. We won't oversimplify the problem, but we'll really try to pull apart the complexity and understand the solutions so we can really address the root causes of the inequities. I just want to say very briefly, I'm sure most people on this webinar know why the election in November matters, but I think this election, more than any others, will really have huge impacts to women and girls and community being engaged and know that women's health and health care is so important in this election. So I want to thank everyone and let everyone know, again, we're going to be opening it up to your questions about 1 minute, but I also just want to talk a little bit about how you can get involved. You can become a member of Breast Cancer Action. You can sign up for news and action alert emails to keep up to date on the issues. You can follow us and join us on Facebook and Twitter to connect with others and help change the conversation about the breast cancer epidemic. You can also help others, speakers and family, about this webinar and other webinars and how they can take action. And last, you can donate to support our education and advocacy work. I want to talk about a few resources and references that I think are important and helpful, and hopefully they will be for you as well. As I mentioned before, the first part of our webinar series, the first Inequities webinar, which was in May, you can find on our website. Also, just to remind you of the Shanti project and their website if you want to find out more information. And also the report that Galen and I both, Unequal Treatment Report, you can find it at the Institute of Medicine's website under reports, and you can just search for unequal treatment. We talked a little bit about, we talked a lot about cultural and language. Kind of weighted, Vivian really talks about what cultural humility is and why we need it. And there's the YouTube link. Also, we're working on a report called Second Webinar into a report, and that is coming soon. You can check back on our website to find out more about that. And last, I wanted to highlight another organization, the National Latina Institute for Reproductive and Connecting Racial Justice and Environmental Justice, if anyone's interested. And again, there are lots of websites on this, and this webinar will be available on our website in about a week. So if you want to refer back to it, if you haven't been able to furiously write down this information, you can go back and refer to it. So I want to thank you all for listening today and remind you that Breast Cancer Action relies on your support to make these webinars possible. Your individual support of our work is really crucial, and if you've been inspired today, please consider making a donation of $25 or more so we can continue these webinars. You can go to www.bcaction.org/donate. I want to give a really big thank you to Galen, Joseph, and Maria Caprio for their presentations today. And now I want to open it up to any questions you might have on this issue. So as we've been going through, people have been typing questions. So I'm going to take a look and pull them out. Here's a question from someone. This is directed either to Galen or Maria. It says, how interested and invested are providers in mitigating communication barriers?
That's a very good question, and I think actually providers are very interested for the most part, and I think they face real challenges on their own due to their workload. I think that's a huge issue. They're often rushing from one patient to the next. They struggle with the lack of adequate interpretation and the kinds of scheduling around getting medical interpreters to their appointments. So I think that they, for the most part, would be open to solutions. Certainly the genetic counselors that I've observed and worked with are very open to improving their communication. I think they and other providers recognize that their ability to take care of their patients in the way that they want depends on good communication. And so, you know, the help that researchers and that other providers like the care navigators at Shanti, the help that we can provide is a benefit to them as well, and I think that they see it that way.
Thank you. Maria, do you have anything you want to add to that?
I would agree with Galen. For the most part, we do see a true desire to want to bridge the communication barriers. And I'll quickly reference, there was, I think, an article, an opinion piece in the New York Times this last weekend that was written by a doctor who was expressing just that, this concern of wanting to really communicate with the client, but their roles are changing. It's no longer that old-fashioned paternalistic role that the doctor has in prescribing treatment. There's now more of a decision-making process happening between the doctor and the patient, and that's a new role, and that in itself is a whole new vocabulary for both the provider and the patient to learn. And so, you know, it's an ongoing question, absolutely, that we're still working on.
Thank you. Thank you both. Another attendee asked, is there a website where we can see the states that Medicaid reimburses for genetic counseling? This person is specifically wanting to know if New York and New Jersey would be part of the states that Medicaid would reimburse for genetic counseling.
So actually, I think the most up-to-date information that I have found on that is on the FORCE website. I think it's probably just force.org. They're an advocacy organization for women with hereditary breast cancer, and they have a wealth of information on their website and support in various forms. But they do also list the states that provide, whose Medicaid programs provide genetic counseling and testing services.
Is that FORCE, F-O-R-C-E, or?
Yes.
F-O-R-C-E. Okay. Thank you. So another attendee wanted to know about, again, getting this presentation. And again, this presentation will be, it's been recorded, and we will put a copy of it up on our website, which is bcaction.org. And you can find it under the resource tab under webinars. And all of our webinars for the past year are on there, so you can look through and review any that you would like. I'll also be sending a PDF of the PowerPoint presentation, so you can have the actual slides as well in a follow-up email that I will send in a couple of days after we have today's webinar and tomorrow's webinar. Let's see, what other questions do we have?
Sorry, just a correction on
Sure.
the name of that website.
Okay.
The name of the organization is FORCE, but their website is actually facingourrisk.org.
Facingourrisk.org. Okay, great. Thank you very much, and I hope the caller was still on to see that.
Yes. I hope so.
Well, I want to give some time for people to write questions. I know we've gone longer than we planned, so some people probably had to leave. I want to remind people that we have webinars every other month, but we will be having another webinar next month, which will focus on our Think Before You Pink campaign. And you can check back on our website, bcaction.org, to get more details about that. It looks like we're wrapping up the questions, so I just want to thank everyone for their questions and their comments today. And if you have a question that you weren't able to ask, you can follow up with us at info@bcaction.org. Again, thank you so much for attending, and please watch your email for a short survey where you can provide feedback on this webinar. Thank you so much, and have a great day.